Here on the Morning Brew, good morning to everybody. I'm Larry Aarons, along with our co-host Aaron Muffaletto for Monday morning. We are really delighted to have at our big round table today two distinguished guests from the UNM Cancer Center, and let me introduce them to you. Dr. Lori Ballinger is here. She runs the Cancer Genetic Counseling Program at the UNM Cancer Center, and we welcome you. Thank you. And we also have Dr. Katherine Morris, who is Assistant Professor in the Division of Surgical Oncology at UNM, and you are a surgical oncologist. Welcome to you too, Dr. Morris. Thank you.
Thank you both for being here so early.
They're used to it. They're you know, she's a physician, and you see counseling patients very early, don't you? Yeah. All right, let's get into it. Aaron, what do you want to know first?
So one of the big things I've been curious of, so Angelina Jolie just announced her double mastectomy news. Now, my big question is, so they did tell her that she had a huge chance of having this cancer, but she didn't actually have it. What really goes into the decision to actually do something like this? I mean, that's such a huge decision, and I don't know, it's a huge preventive measure. Would you recommend it to everybody, or?
Well, I think first of all, it's very important to know that Angelina Jolie has a very different risk of breast cancer than people in the general population. Okay. Women in general don't have a low risk of breast cancer. 13% of us will get breast cancer sometime in our lifetime. But somebody who carries a mutation in the BRCA genes, as Angelina does, has as much as an 85% lifetime risk. So it's very, very different. Prevention in that group is much more difficult because the risk is so high. So prophylactic or risk-reducing mastectomy is one of the options that women use to lower that risk of getting cancer.
And that's just specific to breast cancer, then?
That's specific. This particular thing is specific to breast cancer. There are many syndromes out there that people do risk-reducing surgeries for, and she's going to also have her ovaries removed very soon, because this is really a breast ovarian cancer syndrome.
Wow.
Now, I would imagine as medical professionals, sometimes the light of celebrity isn't always a good thing on a topic, but in this case, it's probably welcome.
Yeah, I think it's been very interesting and very brave of her to share her decision-making process and be so open and frank about it, because so many women are wrestling with this type of decision, knowing that they have this gene, which, by the way, is rare. About 5 to 10% of all breast cancers are thought to be due to a genetic syndrome. So most of them are sporadic, and most people are of average risk. But I think it's important for those that are at elevated risk to be able to consider these choices, and especially in someone who's so, you know, beautiful and renowned for her looks as Ms. Jolie.
And the only reason she did find out that she had this BRCA gene was by genetic testing. Now, genetic testing can be very expensive. Now, what do you recommend to people? I mean, because a lot of insurance won't pay for it either.
Well, one of the things is, you're right, genetic testing is very expensive. And it's not for everyone. As we said, only a few people have a very high risk. So it's very important to know what your family history is, what your ethnicity is, and once those things, if they coalesce into somebody who looks like they're at high risk, then genetic testing is almost always paid for by insurance.
Oh, okay.
But only for those who are at high risk, not for those who are not at high risk.
Right.
Okay. It's the whole idea of a mastectomy or a double mastectomy. It's not scary as it used to be. It seems to be something that women like Angelina Jolie and others, it doesn't seem to be the barrier that it used to be. That was the operation of last resort, if you will. Are you seeing a change in attitude?
Definitely. We've seen a shift. Initially, you know, in the 80s, it was mastectomy for breast cancer, and then we learned through a lot of brave women who went through clinical trials that we could get the same survival with lumpectomy and radiation, and I'm talking about the average risk women. So there was kind of a shift towards breast conservation. And in the 2000s, we've started to see a shift back towards mastectomy and even risk-reducing mastectomies. And it's something something that a lot of people are talking about in the business, and I think it's kind of the other side of the empowerment coin. You know, women are making the decision that they don't want to have to go through radiation, so they choose mastectomy. I think one of the other most important factors is that we've gotten a lot better about reconstruction. So most of our women can have immediate reconstruction if they're not smokers, so they don't have to wake up flat.
If I can follow that up a little bit too, Angelina Jolie is 37, and she was, if I remember right, her own mother died from this at a very early age in her late 40s, and she was afraid to get much older and see this set in. Is this an average age where you're seeing this in the women that you work with?
For women who have genetic mutations, the breast cancers are not only higher in risk, but they're earlier in risk. So that people who have BRCA mutations may have their breast cancer, we've seen them as young as 20, but we see a lot in the 30s and 40s. Most of them happen before the age of 60. So for these are actually really a very different group of women. They're young women, and so around their risk-reducing choices, and as we said, mastectomy is only one of them. We have a lot of support and counseling on both ends of that, because we're such a breast-centric society that it takes a lot of courage to do this.
Right. Now, if I have a lot of family that has this cancer and I'm worried that I might carry the cancer gene, what's the process in going forward to do genetic testing?
Well, first of all, we want you to talk to your doctor to see if they agree, because not every woman who has a family member with breast cancer is at high risk. And then for genetic testing, the standard of care really is to have genetic counseling with somebody like me who can tell you what to expect from the test, what it tells you, what it doesn't tell you, and what you need to do, whether it's positive or negative.
That's something actually I feel really strongly about as a physician and as a surgeon who ends up counseling a lot of women about risk-reducing mastectomy, is that it's critical that they have all of the information, and a big part of that information comes from a certified genetic counselor like Ms. Ballinger. And
when you do genetic testing, it doesn't just test for cancer genes though, right?
Really good question.
There are multiple kinds of genetic testing. We at the UNM Cancer Center, that's the kind of genetic testing that we do. But there are multiple. There's not just one cancer gene.
Right.
If there were, that would make my life a lot
easier.
But that's one of the reasons that you see an expert is someone who can take a family history and say, your family looks like BRCA, or your family looks like this, which is not BRCA, so that you not only get genetic testing, but you get the appropriate genetic testing.
Okay.
In my chats with Dr. Willman over there at the Cancer Center, what she's told me, and I believe to be true, is that this is a real hidden treasure in our community here, that we've managed to put together one of the world's top cancer research institutions right here in New Mexico. And recently 4 new physicians were hired to join the team, and this is a nice trend to see this kind of research going on at this facility right in our community. Can you speak to that a little bit?
Yeah, I think I came here about 2.5 years ago from Portland, Oregon, and one of the highlights for me and one of the things that drew me here was the world-class research that was going on. It was just so exciting to think that I could be a part of that, both as a clinician and as a scientist. And the 4 people that we have got coming in are just making that an even broader and deeper picture. We have 2 people from MD Anderson, 1 from University of Maryland, and 1 from Huntsman Cancer Center in Utah. So it's just incredibly exciting time. So we have a group of young people, and we have also the breadth of experience of people who've worked here for 35 years. So it's a really wonderful place for me to be.
The day-to-day work as your colleagues, as you attract colleagues of this caliber, you really look forward to working with people like this, don't you, from a professional standpoint?
Yeah, it's
like being on an all-star team or something.
Well, and the multidisciplinary nature of the Cancer Center in and of itself is so great to be able to have all of that available to you as any one professional. It's not a solo practice.
It's a team sport. And being able, if I see a patient that I'm concerned about their family history, I can just go down 2 flights and talk to Lori and say, hey, I'm a little worried about this person before I do surgery. Can you counsel them and consider testing? And I have medical oncology there as well, and radiation oncology to talk to, and it's just a really rich environment for dealing with the challenges that we have that are unique to New Mexico.
Plus, as Dr. Willman said, we have some of the best basic science researchers around.
And do our family doctors have to prescribe us to go to the UNM Cancer Center, or can I just, if I have cancer and I want to go to UNM Cancer Center for treatment or to speak with one of you, how does that work?
It's a good question. Often, especially for genetic counseling, I think it's really good to have your family practice doc or your internal medicine doc look at your family history and kind of assess your risk. In terms of coming into the Cancer Center, I think they're pretty open and welcoming. It's one of the things that I've enjoyed about here too. We have less of the concern about are you insured or not. They really bend over backwards to try and care for everyone.
Right, we provide care for everyone regardless of ability to pay.
That's great.
It's so interesting talking to both of you. We're out of time, but I want to thank you, Lori. Thank you for coming. Dr. Morris, thank you very much.